Hey there, welcome to week two. I'm just going to fire off some rapid thoughts I have about evidence-based practices. As you read the chapters this week in Drake and the articles, um, I wanted to give you just some of my thoughts off the cuff. Sort of dressed down today, so these are sort of some informal comments and thoughts I have on EBPs or evidence-based practices. Um, Watching this video should not be the only thing you do this week. The readings are the critical piece and really form the basis of all of the rest of the work we're going to do this semester. So knowing what an evidence-based practice is really important. Not only for the class, but also for your work in community mental health today. Everything that practitioners do really is tied these days to evidence-based practices. And why? Money, cha-ching. Insurance companies are, namely Medicaid, if you're going to be working in the community sector, are tying their dollars and how they fund programs, and we'll talk about all those different kind of programs as the semester unfolds. They're being tied to research, and it's no longer are programs allowed to just kind of do what was always done in the past, which was how things were funded in the past. Now they're really tied to, okay, this has been shown to work, this needs to be implemented in your program, and this is what we're going to pay for. So, historically, psychiatry and psychiatric practice have probably lagged behind the other disciplines when it comes to evidence-based medicine. If you think back, a lot of it was trial and error back in the day when we didn't know what we were doing. Think back really far, it was like witchcraft and exorcisms and really drastic practices to try and either cure or control people with really bad psychotic symptoms. And then as we evolved, eventually, we came to discover psychiatric medication, which had a huge impact on our treatment of people. But still, for the better part of the 19th century and early 20th century, people were often, human guinea pigs as doctors and whatnot tested what worked and what didn't. And when they found something that may have worked, and maybe they knew why and maybe they didn't, it was often passed down and trained on to the next grouping of staff because that's what was always done. So if we didn't really know the definitive reason, we just did what we were taught. So nowadays that we have a body of evidence to support some things that really do have positive implications for people with mental illness, insurance companies and the government has caught on to this, and they are now really forcing community mental health providers and nonprofits to be doing all of these things, or else they don't get paid. So an example might be, say, a vocational program, a agency that assists people with disabilities in obtaining jobs, employment. So they may have had some practices in the past that they did just because that's what they thought worked. And then supported employment came out. Supported employment is one of the major evidence-based practices. It has probably the most amount of literature supporting it. So it is now the preferred method of practice in the state of New Jersey and nationwide probably. And the government and or Medicaid will fund services that are in line with the evidence contained within supported employment. So, for instance, the choose, get, keep model, which we will learn more about when we get to supported employment, is the way that most, if not all, mental health agencies that do supported employment these days operate with that, using the choose, get, keep model. That's how the evidence has been shown to help people, so that's what we do. And so much of it is becoming a numbers game. I remember when I first got into the mental health, community mental health field, numbers really didn't matter. Data wasn't as important. Nowadays, we track everything and we have to report everything. So back to the supported employment program, they have to report to Medicaid and people that fund them, like the Division of Mental Health and Addiction Services, how many people they got jobs for, how many people they have on their caseloads, what their turnover rate is for, are they getting people jobs quickly? How long is it taking? Um, these numbers transcend all of the programs. A PAC team, which we will also talk about, but is in short a team that assists people with real severe mental illness, people that have had multiple relapses in and out of the hospitals, and is really reserved for what they used to deem the treatment-resistant population. They have to report on their hospitalization numbers. So they need to say, oh, this person didn't spend any time in the hospital in the last month. This person was there, and it's becoming much more performance-based, which I believe is a good thing. We should be held accountable, and the numbers should, I think, drive, how agencies get funded or not funded. There, as you could see, probably is a bit of a lag time, though, in how research is published or when it's published, and then the amount of time it gets to actual practice. So if you notice, those articles that were assigned this week were dated back in 2001. And here we are now in 2015. And there are still programs out there that are still implementing some of these EBPs. So sometimes the research to practice lag time is really significant, and I think we need to work as a field to get better at that. That when we see things that have promise and that have been shown by evidence to have good outcomes for people, we need to try these things out and not rely on things that just have been, tried in true practice historically, or without much research behind it, because that was what was told to us, or just what we believe helps people. So you have to really, it's a fine line in psych rehab. So since so much of it is consumer driven, the person has final say over their treatment. So if they want to do a particular practice that may not be backed by evidence, we're not going to necessarily deny that. But we would definitely be educators in that scenario and letting them know, hey, listen, there's this other thing that has been actually been recently shown to have some really good outcomes. Would you like me to talk more about it? That's our role, among many others, as a psych rehab practitioner. So I hope you enjoyed this quick little down and dirty, my thoughts on the subject thing. I'm going to try and do more of these as the semester unfolds. Good talking to you all. Take care.